we've spent time, a lot of time talking about report writing, and I know that this is sort of where, rubber meets the road with respect to being able to get across to your referring providers and to your patients presenting your materials in a concise fashion that helps to give them an idea of what's going on, and it helps you hopefully to collate the data and the information that you've gathered from your EMG and your nerve study to be able to come up with a reasonable impression. And so we've done these types of things before, and I just feel like the more time that we spend going over specific cases and specific reports, the more data that we look at, hopefully the more reasonable things become when you look at a sheet full of numbers. So this is nothing more than continuing to just grow and develop and develop your own styles along with the help of your mentors. So let's just look at those two sensory waveforms. This is off of the same patient. And if we just take a look at it, what does it look like? So if you were to gather this sensory information data, what are you thinking first? What does the waveform on the left look like? And now, you don't have a data table, but this is similar to what you would see whenever you did a sensory nerve conduction, yes?
Yes.
And if you did two nerves, you did the right median sensory nerve to digit 2 or 3, from wrist to digit, and then you did the left median sensory nerve wrist to digit, what does this information tell you? I mean, you guys are doing cases. Go ahead, Kajal.
And when you compare it, it looks like the right, even right side has demyelinating and axonal pathology. Decreased amplitude and just
okay. So you notice good.
Yeah.
Go ahead. Go ahead.
No, I'm just counting the latency.
Mm-hmm.
It was 2, 4, around 6 millisecond.
Yep.
So that's delayed.
And how big is it?
Yeah, it is just 110 microvolt. So what, 0.4, 0.5 millivolt or something?
Yeah, so it looks like it's about 5 microvolts. So the one on the right, can you see my cursor on my screen?
Yes. Yes.
Okay. So the amplitude of this response looks like it's about 5 microvolts. It's about a half of a gradical, and the gradical's 10 microvolts per division. So this is, right at 5 microvolts. And as you counted over, you counted 2, 4, 6. So you automatically get yourself in a habit when you're looking at a sensory nerve conduction study to demonstrate that this setting is at 10 microvolts per division, 2 milliseconds per division, and the right side, just in looking at them, this right side looks much smaller in amplitude as compared to the left. And if we look here that this is 2, 4, maybe 4.1, 4.2 milliseconds, I'm learning a little bit, if I can think of my norms, and I've learned to sort of memorize my norms, that this sensory latency is mildly slow.
Yes.
Let's see, it's about 10, right about 15 microvolts. So we would call that normal in most circumstances, and a little bit slow. But if I move over to the right, I'm definitely seeing, as you said, 2, 4, 6 milliseconds in latency. That's slow with a drop in amplitude. Now, what can't we say about that drop? Say this patient says that they have nighttime numbness and tingling in their fingers. Improves when they shake their hands. It's worse when they're driving a car talking on the phone. Our differential is that they have carpal tunnel syndrome. If we only test wrist to digit, what can't we determine?
That the nerve has, it's a median neuropathy or it's carpal tunnel.
Yes, we see that it's median neuropathy, probably bilaterally. The right looks worse than the left. But what we don't have any idea of is how significant any sensory conduction block there might be at the wrist, because we don't have a palmar stem to digit 3 for comparison. But just in looking at this data, the reason I started with this was just so that you can look at a waveform. This is what we're looking at. So do these waveforms pass Dr. Brooks's sniff test? Are the baselines reasonable? That is, can you draw an imaginary isoelectric line along the baseline to establish a reasonable takeoff? And in both circumstances, I would say that that's reasonable data. Now, again, this is at 10 microvolts per division, and when that's what I look at sensories at. A lot of you guys look at sensories at 20 microvolts per division. So a lot of this jaggedness that you see here, if I were to have this at 20 microvolts per division, would be very smooth appearing. So this is a reasonable, these are reasonable waveforms. And just in looking at them, clearly it appears that they're both a little slow. The right's slower than the left, and there's an amplitude comparative decrement. And the reason that I want to start with a slide like this as we're talking about report writing is because that's what I want you to say. When my trainees write, and we'll go over some examples in a few minutes, I want you to say what you see. Not necessarily let that automated report generator tell you what's going on, because I need to make sure that my onset markers are in the right place, my peak markers are in the right place. These are reasonable. And now I can comment on data. What about this? Same patient.
For sure, the latency on the right is prolonged, and the amplitude on the right is reduced.
It does look comparatively reduced, and you're correct. You're at about 6 milliseconds as far as the latency is concerned. And it looks like there's a comparable amplitude decrement. Now, for those that have been through, when I see a suspicious amplitude decrement, does a decrease in amplitude, what does that mean when a CMAP is decreased?
Axon loss.
Okay. So in this scenario, is it reasonable to say that there's motor axon loss in the right median nerve?
Yes.
Yes, but you have to confirm with EMG.
So if you have to confirm with EMG, is your answer still yes?
If the EMG is normal, yes. Doesn't the that just affects how you're going to grade the severity, correct?
No. If the EMG is normal, I'm going to call that amplitude normal. If the EMG is normal, I'm going to say that there's no motor axonopathy. Because CMAP amplitude, while CMAP amplitude represents axons, and total number of, it's supposed to represent total number of axons and muscle fibers. What is an acceptable side-to-side difference in motor amplitude, typically?
20%?
What does Kimura say? If you don't know, you say 50%?
Yeah, Kimura says exactly that. If you don't know, say 50%. And the old literature, Kajal is correct, 20%. But what I hear you guys saying, which is correct, is there's wide variance. If you look at Bushbacher's comparative side-to-side norms in lots of muscles, 60, 70, 80%, he shows that in normal patients, you may see significant side-to-side comparisons that are outside of what you expect to be that 20% or 50%. So it's important to recognize that when you see, and Kajal hit on this, when you see amplitudes that are suspicious, what's the most sensitive indicator for motor axonopathy that you have as a tool?
EMG.
Needle EMG. And again, just like that sensory nerve at the beginning, what if you shocked in the palm and you saw this?
Yeah.
And you see a very comparable amplitude on the right as compared to the left. So at the end of the day, to say that the right is comparatively low in amplitude to the left is okay. But that doesn't necessarily mean that there's motor axonopathy. There could be partial motor conduction block at the wrist. You could choose to stem in the palm, or you could just stick the APB, which you should do in a patient that presents this way. If you stick the APB and you see fibs and positive waves and motor unit morphology change, well, now I'm confident that that is representative of motor axon loss and not just a normal variance left to right. So in looking at these motors, we look at the data. We see 5,000 microvolts per division. This one's right at 5. That falls within all of our norms. But it's at 246 milliseconds, 5.9 milliseconds. And on the left, we're at 2.4, probably about 4.2. That's right at our upper limit of acceptable norm. And so that data is reasonable, particularly given what the sensory data looked like before. So without even looking at a data table, we should be able to look at our waveforms and determine what do our onsets and our peaks look like? Are our latency markers in the right place? And what's that data telling us? Okay? Because otherwise we look at this table. And this gets a lot hairier, doesn't it? I would like for somebody, please, to summarize the sensory table of this study. Somebody summarize this sensory table. So this information down to here. 1 or 2 sentences. Because now we're writing a report. In 3 sentences, I would like for us to be able to describe motor, sensory, and late responses on this particular patient.
So the latency, amplitude, and nerve conduction velocity of all sensory nerves tested was within normal limits.
Okay. I'll buy that. I would also buy the bilateral sural and left superficial peroneal sensory nerve conduction is normal. So what I saw Kathy do in her head was she took a look at amplitude. I always look at amplitude first because to me it's more meaningful. But then she looked at the latencies and she saw that latencies are normal, amplitudes are normal in comparison to our norms, and there's no abnormality in those three nerves. And then you described it. That's perfect. Would anybody say any different? Brian, what about the motor nerve conduction table? Would you summarize it for me?
Yeah, bilateral tibial motor and left peroneal motor nerves exhibited normal latencies, amplitudes, and nerve conduction velocities.
There you go. Simple sentence. So now we have 2 bullet points in our summary that have summarized that data. That's great. Anybody else want to comment on the H-reflex data? How about bilateral tibial H-reflexes are normal?
Normal, yeah.
So 3 sentences, and we just highlighted everything that we needed to on that particular nerve conduction study. That's great. So hopefully when you guys are writing, that's what we write. Now we add in a little bit of pathology. Can somebody try to say in a couple of sentences what this means?
The median motor has reduced amplitude.
Which one?
The left median motor exhibits reduced amplitude.
What's the most stunning finding on this table on both sides? And I actually bolded it, and I use my little comment section and write it out while I'm doing the test. There's complete motor conduction block of both median motor nerves at the wrists with low distal amplitude on the left.
Oh, okay. I didn't see the NR. Okay.
So you did right by taking a look right here and finding that bold. This was all right. Still lower limit of normal, but this is screaming at me. There's complete motor conduction block of the median motor nerves bilaterally at the wrists with low palm to APB amplitude on the left and amplitude at the lower limit of normal on the right. So it's okay to say it and write it just like that. Let your data come to you and let it talk to you. Now, sentence 2 is everything else. We start with what's abnormal and most significant, and then we identify what's normal. Now, if Dr. Brooks were to write that, he would say all motor nerve conduction in the upper extremities, to include the median and ulnar studies, are normal except, or he would say all motor nerve studies in the upper extremities tested are normal except, and then he would say in one bullet, there is complete conduction block of both median motor nerves at the wrists with low distal amplitude on the left. And that would be his summary of that whole table, right? For those of you that have Brooks.
Mm-hmm.
Yes.
And for me, what I would write is that second sentence. There is complete motor conduction block of both median nerves at the wrists with low amplitude distally on the left, period. The bilateral ulnar motor nerve conduction studies are within normal limits. Is that all right?
Sounds reasonable.
Are we writing that way? Are we, everybody good with that? And are we're practicing that way, correct?
Yes.
Good. So the more we see, hopefully, the easier this becomes. How about this table? Let's start with the sensory. A little more complex. But hopefully we can still describe it in a couple of sentences. Anybody?
There's partial conduction block at or about the wrist, as tested. Yeah, I mean, it's tough for me to talk things out. I always write it out, so it's always tough to kind of talk it out. But obviously, I'd like to say.
But you say it in your head before you type it on the computer.
Yeah, I got you, but get the point. So for me, I recognize it as a partial conduction block at or about the wrist, as tested in bilateral median nerves.
Do both nerves provide enough evidence to say that there's partial conduction block?
Let's see.
They both have prolonged latency and slowed nerve conduction.
What is they both?
The left and right median nerves.
Motor or sensory?
So bilateral median sensory nerves exhibit prolonged latency and slowed nerve conduction velocity.
Where?
At or about the wrist.
Okay.
Yeah.
Because now,
The short segment's normal.
The what segment's normal?
The short segment in the palm is normal.
The distal segment, you mean? This segment?
Yes.
Yes. Okay. So how I write this is I say, I look at sensories first, and I go down to my comparisons to digits 1. I see that both my median versus radials are slow. I've got a comparably low amplitude or a low amplitude on the left side in the sensory And up here, I look at these amplitudes and I say, well, side to side, the right side to D3 is low. And I see that the latencies across the wrist, which result in transcarpal velocities being slow, are there. So that's what I see when I look at the table. And so when I write that, I would say something along the lines of the bilateral median sensory nerves demonstrate delayed latencies across the wrist with slowed transcarpal velocities, low left median sensory response to digit 1, and comparably low right median sensory amplitude to digit 3. In my next sentence, I might now describe what's happening in my motor nerve conduction. And what would you say there? What's important to say? Brian, you hit on this right off. Anyone?
So the left median motor has prolonged latency, but the right median motor has, I mean, you've got it written there. There's a partial motor conduction block at the wrist.
Okay.
It's got a prolonged latency at the wrist, as well as a slowed nerve conduction across the palm.
Or across the wrist, yeah.
Or across the wrist, sorry.
So to shore that up a little bit, if Brooks was writing it, what would he say?
The right median motor nerve exhibits prolonged latency, reduced amplitude, and slowed nerve conduction velocity at the wrist. This is my mind is not working this evening. This is indicative of partial motor conduction block at the wrist.
Okay.
I don't know that we would put it into 2 sentences.
It's all right. It's okay to use more than 1 sentence, but what's Kajal got to say?
Okay. Bilateral median motor nerves showed prolonged latency at the wrist, and right median motor showed partial conduction block across the wrist.
I'm okay with that too. I'm also okay with the bilateral median motor distal latencies are delayed across the wrist, parentheses, right greater than left, with partial motor conduction block at the right wrist. Bilateral ulnar motor nerve conductions within normal limits. Bilateral superficial radial nerve conductions within normal limits. Good. So a few sentences to hit the highlights of how your data presents. So if we were looking at that and that was all that we had, and say that the EMG was normal, what would our impressions say?
This is an abnormal study.
Good.
And there is an electrophysiological evidence suggestive of moderate, mild to mod. Like, you know, in first stage when we learn, it says like when there is motor nerve involvement, you say it moderate.
Okay.
And so, yeah, moderate sensory motor demyelinating pathology affecting bilateral median nerves at or about the wrist. There is no other electrophysiological evidence of any radiculopathy,
Well, you don't have an EMG.
myopathy.
You don't have an EMG to identify radiculopathy or the other, but I did say if the
No,
EMG
you
was
said
normal.
yes.
You're right.
You
You're
said
right.
EMG was not. Yeah. Okay.
And would it be worth saying that the right's worse than the left?
Yes.
Okay, good. Anybody want to say it differently? When I write it, I would say that there's moderate bilateral median focal neuropathy at the wrist, right greater than left. And then as Kajal said, what isn't it? Okay, it's good.
Okay.
Everybody copacetic? We're jiving, right? We're gonna move past this. Okay, I'm gonna back out and we're gonna go to some other stuff because this really is what I want to focus on. Give me 2 seconds. Somebody summarize that data for me. Just from an EMG summary perspective. Somebody. Brad? It's gonna go ahead, Kathy.
Well, there's a focal neuropathy.
No,
I'm
don't
just
say there's a
gonna
focal neuropathy. I want you
Yeah.
to summarize just the EMG data as though you were writing it on your report. Don't give me an impression yet. I don't want you to give me an impression. I want you've got to tell the reader what your EMG data demonstrates.
The left first dorsal interossei and abductor hallucis muscles exhibit fibrillation potentials and positive sharp waves and rapid recruitment.
Is that all?
Oh, and increased amplitude.
What? Increased amplitude motor units.
Yes.
Or larger than normal amplitude motor units. And so what does this mean? What does it mean when we see fibs and positive waves? What does that mean to us?
There's muscle membrane instability.
Very good. It doesn't mean that there's a neuropathy. It means that there's membrane instability. Membrane instability could be the result of axonal pathology or muscle degeneration, right? But what is it that tells us that this is axon loss pathology and not muscle degeneration?
Seeing the increased fast firing.
Rapid firing recruitment, which implicates that there's reduced recruitment. There are not as many motor units available, so the ones that are firing don't have others to pick up their slack, so they fire rapidly. Good. That's neuropathy. And what are larger than normal amplitude motor units represent? Why is a motor unit larger than it's supposed to be? What happens neurophysiologically to make an amplitude of a motor unit larger than it should be? Anybody remember? How do nerves heal? Two ways. Muscles reinnervate by two different mechanisms. What are they?
The regeneration or collateral sprouting.
Yep. And how does a motor unit become larger than normal? What does a large amplitude motor unit represent? One of those two things. It represents mature collateral axon sprouts. Everybody remember that? What is a large amplitude, or what does a long duration polyphasic represent?
Some type of regeneration.
No. A long duration polyphasic of normal amplitude represents immature collateral axon sprouts. And as those axon sprouts become more synchronous, the duration of that potential decreases, the number of phases decrease, and the amplitude increases. So large amplitude motor units reflect motor axonopathy that is mature by way of mature collateral axon sprouts. So when we look at an EMG table, I break it down into three sections: insertion and rest, motor unit morphology, and recruitment. Okay. Now, in and of itself, changes in insertion and rest, as Brian had indicated, represent membrane instabilities. And membrane instability occurs from one of two things. What were they?
Is some type of myopathy or
Axon loss.
Or axon loss. Very good. Good. Now, typically, that's an active process, yes? Ooh, that's loud. That's an active process. If an injury were a new injury, say a month old, would you expect to see any changes in morphology? Yes or no?
No.
Why?
Because when it's just a month old, we haven't had chance for regeneration to happen, correct?
Yeah, collateral sprouting or axon regeneration. That's right. Now, recruitment certainly could be rapid in an acute or active process, but we wouldn't expect to see morphologic changes occur in the first month or two, right? So if you were qualifying this data, as you had said before, Kathy, one way to demonstrate what this data is that there is evidence of membrane instability with large amplitude motor units and rapid firing recruitment in left posterior tibial innervated muscles of the foot. Okay, both medial and lateral plantar divisions. Remaining muscles From the bilateral lower extremities, representing the L2 to S2 myotomes, including the paraspinal levels, demonstrate normal resting activity, motor unit morphology, and recruitment. 1, 2, 3. Now, another way to say that might be to say that there is evidence of active and ongoing denervation, because we know now that because of the increased amplitudes and the rapid fire recruitment, that this is axon loss pathology. We know it's not new. It's old enough that we've got large amplitude motor units. We know with the fibs and positive waves that it's active. There is active denervation in the left posterior tibial innervated muscles of the foot. Remaining muscles in the sample, representative of L2 to S2 distributions, including their paraspinal levels, are normal. So it's important as we sit down to see data to be able to say what it means, because that means a lot in our impression, doesn't it? Now, whether or not this is a patient who has tarsal tunnel syndrome, or whether this is a patient that has, some distal motor axonopathy, we still have to compare that to our nerve conduction data. But it's important to me that we understand how to say what our table says, and that we understand it when we read our table, because we're the ones that are filling out the table, right? The computer's not going to fill this out for us, right? I mean, you guys don't do an EMG and your table fill itself in. It does do it in our nerve conduction, but it doesn't do it in it fills it in for us as all normals. But when we see abnormal, we've got to say what the abnormality is. Is everybody okay with that?
Mm-hmm.
All right. So I like to look at what's abnormal first, what's normal next, and then order it by what's most significant. So, of course, in a nerve conduction, is latency normal, prolonged? Is amplitude normal, is diminished? Is velocity normal or slowed? Is there evidence of conduction block? And in the EMG, what's insertion and rest look like in comparison to motor unit morphology, recruitment, and interference patterns, so that we collectively can summarize that data in our impression. So, examples. In carpal tunnel syndrome, the bilateral median sensory latencies are delayed to digits 1 and 3 with slowed transcarpal velocities, normal amplitudes. The median motor distal latencies are mildly delayed with slowed transcarpal velocities, normal amplitude, normal proximal velocities. Then what's normal? You can be comprehensive, but you can also be concise, because doctors don't want to read 9 bullet points about what's normal and what's abnormal that doesn't really mean or say anything. And for you guys to be able to look at a data set, to be comprehensive but concise, will help you when you're writing a report. If you can look at a group of data and synthesize it so that you can spit out a summary of it, then you're only going to be better. Couple of examples. The top's Dr. Brooks's and the bottom is mine, and I would usually bullet mine. So there's a person with tarsal tunnel. The left medial and lateral plantar sensory responses weren't recorded. The left tibial motor transtarsal velocity was mildly slowed. And I might write it, the left median lateral plantar sensory nerves are not elicited. There are also focal delays of the medial lateral plantar modal transtarsal segments with no evidence of conduction block. Then everything else is normal. In an EMG, note what's normal and what's abnormal. And again, we break it down into insertional activity. Is it normal? Is it increased? Is it decreased? What's the spontaneous activity? Are there fibs, positive waves? Are there CRDs? What is it? We generally quantify it. What's the motor unit configuration look like? Is it lower than expected? Is it normal? Is it increased? So this is a very important slide because in EMG, and this is what we were looking at with respect to this slide up here, guys. What this tells me is that this is ongoing pathology. There's active, that's older, and that's more significant. Okay? So this is ongoing neuropathy when I see evidence in all three places. Interference patterns are abnormal. Motor unit configuration is abnormal. When that's abnormal, it tells me that it's actively or chronically reinnervated due to collateral sprouts. Go ahead.
Thank you. Oh, sorry. I was talking to my husband. Sorry, Mark. Or sorry, Rick.
That's okay. We sound just alike. He talks a lot slower than I do. And we know that with all these fibs and positive waves that it's an active process. So when we go down to our summary in EMG, this slide, when a muscle is normal, insertion's normal, there are no resting activities, there's no abnormal motor unit morphology, and recruitment is full. In acute and ongoing, let's just talk about acute neuropathy. Know that these two, 1, 2, and 3, active equals 1 and 2. Chronic is 3. And just look at the pattern. Acute neuropathy, increased insertion, fibs and positive waves, but normal morphology. There hasn't been time, Kathy, right, for collateral sprouts or reinnervation to have occurred from regeneration. Recruitment may be normal, could be reduced in rapid fire, depending on how severe the neuropathy is. Ongoing neuropathy implies some increased insertion, fibs and positive waves, evidence of motor unit remodeling due to collateral sprouts, long duration polyphasia, large amplitude motor units, and the recruitment may be normal if it's very mild, reduced in rapid firing if it's more severe. Chronic neuropathies, however, generally have normal to decreased insertion, normal versus really small amplitude fibs and positive waves, but are predominant with the large amplitude, long duration polyphasia and the recruitment changes. So in a patient that has a chronic C7 cervical radiculopathy, you may see completely normal, let's just pick 3 muscles, the extensor digitorum communis, the tricep, and the FCR. 3 muscles that share C7. Old C6-7 cervical disc fusion, You stick their FCR, and it's normal with insertion, it's normal at rest, but you see large amplitude motor units with some reduced and rapid firing recruitment. And you see the same thing in the tricep, and you see the same thing in the extensor digitorum. That's chronic C7 cervical radiculopathy. Does that make sense?
Mm-hmm.
Versus seeing, if you see large amplitude fibs and positive waves, increased insertion with the same large amplitude motor units in those same 3 muscles, what is it? Kathy? Large amplitude fibs, large amplitude, same 3 muscles. We've got FCR, extensor digitorum communis, EDC, and triceps. We stick those muscles and we see the same large amplitude units, but we see large amplitude fibs and positive waves with increased insertional activity. Is that acute, ongoing, or chronic?
No polyphasics?
No, I said large amplitude motor units and a few polyphasics.
So it's ongoing.
Ongoing.
Good. Good. Same 3 muscles. We see increased insertional activity. We see fibs and positive waves, but we see normal motor units. Is it acute? Is it ongoing? Or is it chronic?
Acute.
Good. Now, you take that information and you apply it to the same table. In this scenario, is this acute, chronic, or ongoing? Is this acute? Is it chronic? Or is it ongoing?
How do we know from that if it's small?
Well, I say it. I have another tab in my description that says, whoops, I'm having a hard time drawing. Must be the bourbon.
So this is chronic.
Yep. No, it's ongoing. If I had written over the 2+, if I had written less than 100 microvolts right here, then that would be more indicative of chronic.
Oh, I thought that's what you were writing up there, telling us it was.
No. I said I have a separate drop down. I have 1+, 2+, 3+, 4+, less than 100 microvolts.
Okay, so since it's not saying that, then it's ongoing.
That is correct. Good, Kathy. Good. So now we can look at a table and characterize what it is that we see without having to say the left first dorsal interosseous and then in parentheses lateral plantar S1, S2 shows 2+ fibrillations positive waves, increased insertion or increased amplitude and rapid firing recruitment. I want you to know what that means. That's evidence of ongoing denervation. It's not new, it's not brand new, it's not just old stuff, it's active and ongoing stuff. There are changes that are happening in that muscle, right? So, let's do some more stuff. What about, you guys are okay writing impressions, right? How you write an impression? So you guys summarize this data. We'll just do more of the same stuff. Case 1, nerve conduction summary. Somebody want to jump on it? I know everybody's still reading the table, but when you got it, just jump in. And hey, I'm cool with talking to the same people all night. So Kathy, Brian, because y'all jump in.
So, I mean, being Dr. Brooks person, everything is normal.
Okay.
That I'm reading. So I don't have that memorized in my head how we write it, but all.
Do you use a template?
I use a template.
Yeah, throw that shit away.
Well, we don't use a template for writing what's abnormal, but when it's normal.
Okay. So it would say something along the lines of all selected sensory, motor, and late responses in the bilateral lower extremities are within normal limits.
Yes.
Is that an okay?
Mm-hmm.
The template's going to say something along those lines, right?
Right.
In fact, I'll tell you what it says. Here's one. Where's one of Mark's?
Yeah, using surface electrodes and percutaneous, like that's the part I don't ever remember. But we would say all motor and sensory nerves, including H reflex, bilateral H reflex, and were within normal limits.
Right. And no except. You would just say put a period after velocities on this sentence here. Right?
Yes.
Okay. And I'm cool with that. So that's what you would say there. So selected motor sensory late responses from bilateral lower extremities demonstrate normal latencies, amplitudes, and nerve conduction velocities, period. That's good. If you wanted to write it out the way I did, I would bullet it and demonstrate that the bilateral sural, left superficial peroneal, and left medial lateral plantar sensory nerve conduction is normal. Next bullet, the bilateral tibial left peroneal motor nerve conduction studies are within normal limits. Next bullet, the bilateral tibial H reflexes and left peroneal F waves are within normal limits. And so I had 3 bullets that essentially say what you just described as well. So that's cool. Good. The EMG, what do you say there?
All muscles tested. Oh, you can go, Brian.
No, that's fine, Kathy. Hit it. You got this.
All muscles tested exhibit normal insertional activity. Well, no, I don't got it right now.
Yeah, you do.
Insertional activity.
Motor unit morphology and recruitment pattern.
And recruitment, yeah.
Yep. And I might use I I kind of lump these together. So I would say something like insertion, rest, and then morphology and recruitment, 1, 2, and 3. You see it? It's important. It's important for me, for you guys to see that, because that's what you write. And then if you wanted to characterize this, I might say something along the lines of muscles sampled from the left lower extremity representing the L4 through S2 myotomes demonstrate normal insertion and resting activities, motor unit morphology, and recruitment. Period. Good.
Dr. McKibben.
Yeah, man.
Would you do me a favor?
Sure.
For me, talk me through collateral sprouting, like what we're going to see in the process of regeneration and collateral sprouting, so I can get my head wrapped around that, because I'm still struggling with that. And I know I've learned it and been taught it 300 times.
It's okay. It's actually why I pull up something that we've probably all seen before, because we see the same thing. And when Kajal was on with me earlier, it's like I hear the same stuff presented differently, a little bit different, and I walk away with something every time. And that's it. I mean, this is see it again, see it again, see it again, right?
It's not sticking for me, and I know I should know this.
Oh, it's okay. First thing we see is a motor unit. That's normal. Okay. What is the typical size of a type 1 motor unit? Anyone?
500 to 1500.
There you go. Yep. And what about a type 2 motor unit?
Up to about 4,500.
Yeah, up to about 5,000, right? Okay. And that's why 5,000 generally is what we consider to be our cutoff of what normal is. But realize that when we evaluate amplitude of a motor unit, what do we say you need to see? You need to isolate a motor unit, don't you?
Yes.
So you need to have 1, 2, no more than 3 motor units on a screen to see amplitude and firing frequency. And which are the first motor units that fire? Type 1s or type 2s?
Type 1s.
Type 1s. So when we initially ask a patient to give us a little effort when our pin's in the muscle, we should see typically type 1 motor units firing at a range of 5 to 12 hertz, and the amplitudes of those type 1 should typically be in the 500 to 1500 microvolt range. You were exactly right, Brian. But if we see one that's 5,000, 6,000, 7,000 microvolts, and we're isolating those units, those are very large type 1 motor units, aren't they?
Mm-hmm.
Now, you ask the question, how do they get that way? With respect to the 2 types of reinnervation, you have axonal regeneration, which you guys are never going to see unless there's a near complete lesion. Think about a tree. If a tree has branches on it, and we cut off this branch and this branch, how is that canopy going to come back? It's going to come back because this branch sends new growth out to here, and this branch sends new growth out to here, so that our tree now looks like it used to, right? That's collateral axon sprouting. That process, before we ever see it with an EMG, is going to take 8 to 12 weeks. Okay? Now, the process of axonal regeneration, we take the same tree and we cut it off right there so that we have an end bulb that now starts to send new sprouts to reach its target organs. Is a much slower process, and that's your millimeter a day. Okay?
Mm-hmm.
Unless we have a complete lesion, these guys way back here are never going to get there, because these collateral sprouts on nerves that are closest to the canopy or closest to the target will send collateral sprouts that get there much faster. Okay? So while axonal regeneration at a millimeter a day will occur, we're not going to see it in an EMG. We're going to see evidence of collateral sprouting unless we see a complete lesion where there aren't any axons left to collaterally sprout. Does that make sense?
Mm-hmm.
Okay.
Yes.
So morphologically, from collateral sprouting, when these guys first get there, they're going to be not very well myelinated. They're going to be slower because they're not well myelinated. And a few of them are going to get there at different speeds.
Mm.
And what is this?
Polyphasic.
And is it short in duration or is it long in duration?
Long duration.
It's long duration. So the amplitude of that collaterally sprouted, reinnervated motor unit now has new muscle fibers that are representative out here, right? And they're going to be long in duration. They're going to be highly polyphasic, and they're going to be fairly normal in amplitude. But with time, the synchrony of firing as these collateral sprouts become more myelinated is going to be more synchronous with the original motor unit. Okay? And when that happens, these phases will begin to go away. So the duration will shorten, but the amplitude is going to increase. So this is normal. This one here is ongoing. And this is mature. Hard to write with a mouse. Does that make sense now?
It does.
Does that make sense to everybody? Kathy, you jiving?
Yep, that does. Yep.
Cool.
Sorry to slow that process down, Kathy.
No. Hey, this is incredibly.
No, that was really important.
This is incredibly important, and it's not a simple technique, but it's important because when you see it, you need to be able to immediately say, "This is what this means. This is what it means to my patient." Now, when is this important? This is important when somebody walks in and says, "I started this new job last week, and my hands are going to sleep." And they've got carpal tunnel, and they've got huge motor units in their APB. Well, that shit didn't start last week. There's no way that this process is a week old.
Right.
And other than that, that's about all it means. Now, axonal regeneration. You lose axons, you have no motor units. When these little bitty guys first reach a muscle fiber, it looks like a fibrillation. And then when more of them begin to reach, it looks like that. You have multiple, it almost looks like these guys here at small amplitudes are beginning to kind of meld together. And so you have these long duration but low amplitude polyphasic units that are small. And as those become more synchronous, then the duration gets a little bit shorter and the amplitude starts getting a little larger until that motor unit looks normal. So this is sprouting. And this is regeneration. Both of these are reinnervation. Isn't it beautiful? Can't write, but isn't it nice? And does it make sense?
It does.
Excellent. Excellent. That's important. That was a very important question, Brian, so I appreciate you asking it. And everybody's okay with it?
I'll see you tomorrow when I do some more tests.
Good. It's important to know when you do that test. So what was the impression from 1? How would you write that impression? We saw all sensory motor nerves and late responses are normal. All EMGs are normal. Impression?
This is a normal study.
This is a normal study, no evidence of blah, blah, blah. Case 2. Simple right upper extremity case. You're going to see this patient tomorrow, Brian. So go for it. First, we got to write the summary. Then we're going to write the impression. You know, I'm sitting here looking on this thing. I wish we could add a text box so that we could type. We only have drawing. We don't have typing. It would be so much easier if we had typing. Brian, would you please summarize this sensory and motor nerve conduction study?
Okay, sensory, we have
Right.
latency.
Wait. Is Dr. Brooks your mentor?
He is.
Okay. Then say what you're supposed to say as though Dr. Brooks were writing this report.
Okay. Well, he has an excerpt that he uses in the beginning of all his sensory and motor tests, and selected upper extremity nerves, sensory and motor nerves were tested in the right upper extremity. There is electrophysiological evidence of prolonged latency of the right median sensory median nerve let's see, amplitude looks good. And slowed nerve conduction velocity.
Okay. Bullet number 2.
You want me to go down and call what's normal and what's not? Is that?
No, you've already said. What I heard you say was that percutaneous nerve stimulation of selected of motor, sensory, and late responses from the right upper extremity all demonstrate normal latencies, nerve conduction velocities, and amplitudes, except.
Sure. Okay. Like I said,
bullet 1, delayed right median sensory responses to digits 1 and 3 with slowed transcarpal velocity, period.
And
bullet 2,
there's prolonged latency at the right, median motor. Amplitude looks good.
Yeah, but you already said it looked good. We just said except.
Okay.
So what I heard us say is that everything is normal except that.
Okay.
So if Mark were writing this, he would say percutaneous nerve conduction stimulation of selected right upper extremity sensory, motor, and late responses demonstrate normal latencies, conduction velocities, and amplitudes except, and then he would say bullet 1, there's delayed median sensory latencies to digits 1 and 2 with slowed transcarpal velocity, period. And then bullet 2 would say there's slowed median motor distal latency across the wrist, period. And that would be the end of his summary. Is that right?
Yes.
And if I were writing it, I would say the right median sensory latencies to digits 1 and 3 are delayed with slowed transcarpal velocities and normal amplitudes, period. The right median motor distal latency is mildly delayed with otherwise normal amplitude and proximal conduction velocity, period. Next bullet. So bullet 2, the right ulnar and superficial radial sensory and right ulnar motor, and in parentheses with F waves, demonstrate normal nerve conduction study, or are normal, within normal limits, period. So we're saying the same thing. Okay. Nerve conduction. I'm sorry, EMG.
So per Mark, it would be all muscles examined exhibited normal insertional activity, electrical silence at rest, and normal motor unit configuration and recruitment.
Except. Thank you.
Well, there is no except in this one.
Increased amplitude. Sure.
Oh, man, my eye.
It's okay.
Tonight. On my test, it was all normal.
Except
the right abductor, and then bullet point 1, right abductor pollicis brevis exhibited increased motor unit
amplitude.
Very good. And then I might say there are large amplitude motor units in the right APB. This suggests mature collateral axon sprouts without any evidence of ongoing denervation. Remaining muscles from the C5 to T1 myotomes are within normal limits. Is that okay?
Yeah.
Mm-hmm.
What's your impression?
So that was a right. The EMG was on the right abductor pollicis.
So the only thing that I have a question about is quantifying whether it's mild or moderate. So this is an abnormal study. There's electrophysiological evidence of it. Where I would be mild/moderate, demyelinating sensory motor neuropathy at or about the wrist / carpal tunnel. So for me, my question would then be to go reference whether or not just because there is EMG abnormality and there's slight median motor prolonged latency. So I guess it would quantify it as moderate now.
And we also put that it's chronic, because if it's just got a large amplitude motor unit and the polyphasics are gone.
Nah. All we've done is we've demonstrated that it's chronic in terms of what you see in the EMG. There's evidence of more chronic EMG change. That's a typical finding in a carpal tunnel. You're going to see large amplitude motor units without a lot of increase insertion, just because carpal tunnel is a slowly gradual progressive problem. You'll see large amplitude units without a lot of evidence of fibs and positive waves regularly. This is a patient that most likely said, yeah, my hand's been falling asleep for years, gradually getting worse. And it used to not bother me. I tried wearing splints for a while. It got better, so I quit using them. It came back. Now it's bothering me when I drive. It's bothering me when I talk on the phone. Still goes to sleep at night. It's an old problem, but in severity terms, it's moderate. And it's sort of right on the borderline of mild to moderate. Good. So my summary here would be evidence suggests mild median neuropathy at the right wrist, period. No evidence to suggest any superimposed processes, period. Okay? And if you wanted to say mild to moderate, then that's fine too. I wouldn't beat you up over that at all. Number 2.
And what's the EMG look like?
Well, would you please summarize the summary first?
Oh, sorry. The only amplitude and latencies that I'm not familiar with but it's pretty straightforward, going to be the plantar. But bilateral sensory motor of the lower extremity tested are within normal limits from my first gander.
Yeah, I don't have good amplitude norms for medial lateral plantar sensory responses. When you get them, it's good. If you don't get them, then it's not as good. But so I don't have a good norm for those sensory responses. Reasonable norm of greater than 35 meters per second is acceptable. So that's why they're listed that way, and there is no norm amplitude here. If you notice when I did a radial sensory response to digit 1, I record out on the digit whenever I'm doing carpal tunnel screens, and I don't have a good norm. 10 microvolts is a good norm when you measure down on the metacarpal, but I'm measuring out on the digit, and frankly, there's too much variability to establish a reasonable norm. So if you wanted to compare them side to side, you could, but in this circumstance, the reason I tested the radial nerve was more of a comparison to the median nerve here. And that's fine. That's normal. So in this circumstance, I wouldn't consider a detectable response with a good velocity, a good latency, as being abnormal in any way. So here, your summary is going to say, okay, we'll do Dr. Brooks's first. Kathy, you got it memorized?
I won't lie, I have it open in front of me. So using surface electrodes and percutaneous stimulation, selected bilateral lower extremity nerves were tested. Testing included motor, sensory, and H-reflex tests. All nerves tested exhibited normal latencies, amplitudes, and conduction velocities.
Period. Good. And if I were writing it, I would say the bilateral sural, medial plantar, and right superficial peroneal sensory nerve conductions within normal limits. The bilateral tibial, right peroneal motor nerve conduction studies within normal limits. The bilateral tibial H reflexes, right peroneal F waves within normal limits. 3 bullets, done. Good. We add to that an EMG. First, the summary, then given the nerve conduction that we just had, stab at the impression. Don't stab. Be concise and accurate.
So for me, this is where I kind of end up getting wordy when I start doing EMG. When you're looking for things you can put in the same category to say similar stuff.
Good. Okay. So
you know what I mean?
Yeah, I do. I know exactly what you mean, and that's why we're doing this. So again, I look at what's in common, and then what does this show?
Sure.
So it's just a box. So let's go down to first what's in common. We got medial gastroc. If I look across the table, we have right medial gastroc, left medial gastroc, right peroneus longus. We have right L5S1 paraspinals. We have left L5S1 paraspinals. What's in common right there?
They all have increased insertional activity.
No, we are not there yet. What's in common?
S1.
S1.
Oh, okay.
Or lumbosacral. But that doesn't say L5. That means lumbosacral LS, not a 5. So whether you chose to say lumbosacral S1, that's fine. Now, if we look across the table, now we see what we have in common is bilateral S1. Now, let's break down bilateral S1 into what does it say? Is it active, which equals acute and ongoing? Or is it chronic?
It's going to be ongoing.
Yep, I was ongoing.
Ongoing. So you could demonstrate, Dr. Brooks would write what, Kathy? You have it right in front of you. Using a sterile monopolar needle electrode, muscles sampled from the bilateral lower extremities all demonstrate normal insertional activity, resting activity, motor unit morphology, and recruitment, except...
Right.
No.
Medial.
There's evidence of ongoing denervation involving muscles from the bilateral lower extremities and related paraspinal sharing the S1 distribution period.
He would have us listed out.
Okay, that's fine.
See, but I jumped to that. That's what I would kind of...
I jumped to it too.
Mm-hmm.
So when, and it's okay, either one. I guarantee you that if you wrote it that way, if he dings you the next time you write it the way I'm telling you to write it, you tell him to call me.
No, I'm not worried about getting dinged. For me, it's all about mastering it and being able to justify what my response is and be able to explain it. And sometimes the regurgitation to me becomes, okay, how does he want it said in such a way? So that's where I appreciate the process, but I appreciate the learning differences when we have different folks presenting. So I appreciate it.
Sure.
Yeah, it makes more sense how you're saying it, Rick. It makes you think it more. And to me, a physician reading it, you send that to a GP, it's going to make more sense. They're seeing the S1, boom, right there.
That's it.
They want to know what the problem is.
Yep. So if I were to write this, I would say in my table, muscles from the bilateral lower extremities and related paraspinals sharing S1 innervation demonstrate evidence of ongoing denervation, period. Remaining muscles from the L2 to S2 distribution, including their related paraspinals, show normal insertion, rest, and volitional activities. And I'm done.
Cool.
Now, what's my impression? This is an abnormal study.
There's electrophysiological evidence of an ongoing, well, I mean...
I'm good. You're there. Ongoing.
I feel like you just stated this, though.
I just said that there's evidence of ongoing denervation involving multiple muscles from the lower extremity and related paraspinal sharing S1. I didn't call it anything.
Right.
And listen, when you write, remember when you were in school and you had to write a paper?
Yes.
Your physical examination is your introduction, right? Your summary is the body of work that essentially is correlating with the patient's presentation. And your impression is your conclusion chapter. So you tell them what you're going to say, i.e., how the patient presents. This patient may have presented with diminished S1 reflexes, low back pain with radicular symptoms following the S1 or lumbosacral distribution, positive straight leg raise. That's probably how this patient, pain with prolonged standing and walking improved with leaning over on a grocery cart and sitting, right? This may be a patient with, lumbosacral stenosis bilaterally, right? So there's our introduction. Our nerve conduction studies are all normal. Our EMG summary is that there's multiple muscles sharing the S1 distribution that show evidence of ongoing denervation. Everything else is normal. And my impression is evidence suggests what? Ongoing bilateral, lumbosacral, parentheses S1, radiculopathy or nerve root compromise, or however it is that you choose to say S1 nerve root problem.
One way to check here.
Right?
Mm-hmm.
And all of those are okay. We okay there?
Mm-hmm.
No, absolutely.
Great. How about this one?
Let me try my way to see if I'm right.
Rick, I'm sorry, but I'm going to need to jump off now.
No.
Not that I don't want to do it, but it's I've got to get to my family now.
Okay.
It's earlier here. It's not bedtime. It's bedtime for you.
Yeah, it is. But we're at 4, and this is the last one.
Okay, I can go a few more minutes. I've got dinners hitting the table here.
Yeah, us
I'm
too.
getting
My dinner's cold. my dinner's cold. So let's go through it quick. First, let's look at the data. What does this show? We selected some upper, we selected some lower. And what's the problem?
So there's demyelinization, so we're thinking of poly.
Yeah, low and slow.
Low and slow. So all blah, 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 except bilateral median slowing with low amplitude and slowed transcarpal velocity in the median nerves, delayed low amplitude surals, delayed low amplitude left ulnar with no response on the right, no response to the median sensory nerve, delayed low amplitude median sensory response to digit 1 with comparative slowing as it relates to the radial sensory nerve to digit 1. So what we see here is evidence of peripheral neuropathy with superimposed median nerve in the sensory table. That's what I see quickly when I look at this data, because Kathy's got to go to dinner. I'm messing with you, Kathy.
You didn't say it, I was going to say it, so.
It's late. So, but here, yes. But you guys called it. Well, it looks like a poly. So how do we characterize that? We just did, right?
Yes.
Okay. Motor summary. When I look down through the data, things that jump out at me is that corresponds with that superimposed median nerve.
Mm-hmm.
Got some ulnar slowing. I got some decreased ulnar amplitudes. I've got a delayed median F wave. Peroneal motor looks good. So again, I've got evidence that still looks like from the motor polyneuropathy. I've got median neuropathy, and then a questionable, I don't even think questionable. It doesn't really look like that slow at the elbow. That looks diffuse to me.
Okay.
That's a little slow. But this is a pretty typical polyneuropathy with superimposed, it's normal for polyneuropathies to demonstrate slowing happening in areas that are common for focal entrapments, right? You'll see lots of patients that look like bilateral carpal tunnel, bilateral ulnar neuropathies at the elbow. You check a sural and it's gone, or the peroneal is a little slow at the knee. That's very common. But you're picking up on the polyneuropathy, aren't you?
Mm-hmm.
EMG.
Seems like in Wyoming, all I'm testing is polyneuropathies.
A lot of drunks.
Yeah, a lot of Southern Louisiana diabetics.
Yeah.
Diabetics and alcoholics.
Mm-hmm.
Nothing else to do in the winter besides have children, and I bet there are tons of kids born in the fall.
Definitely in my house.
Yeah, definitely at your house, but you don't live in Wyoming. So what does this say? First of all, what's the distribution, Kathy?
I don't see it on my screen yet.
What? Oh, you're in Wyoming. Give it an hour.
But did you put the EMG up there?
Yeah. Do you see it, Brian?
Yeah, I see it.
I don't.
Okay, what we see, Kathy, is evidence of ongoing denervation in muscles from the bilateral lower extremities, right upper extremity, and right lower thoracic paraspinals. And what I would say, you see it now?
Now. It just came over.
How I would write this is that there is evidence of diffuse, ongoing denervation noted in muscles from in a limited sample of muscles from the bilateral lower, from the right lower, right upper, and right lower thoracic paraspinals, not following any particular myotome, peripheral nerve, or plexus distribution, period. That's it. There's ongoing denervation in this patient that doesn't follow any pattern, because we went here, here, and here, and there's evidence of ongoing denervation. We've agreed based on tonight's presentation, correct?
Yes.
Then we come over here and we say, well, what's the pattern? There isn't one. I got thoracic paraspinals. I got 5-6. I got 7-8. I got 6-7. I got S1-2, 2-3-4, 4-5. There's no pattern. There's no pattern to nerve. There's no pattern to root level. There's no pattern to plexus. It's diffuse. So what's the impression? Is there demyelination?
Yes.
Slow, 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 slow. Slow. Is there axonopathy?
Yes.
The EMG and the nerve study. And is it motor and sensory?
Yes.
Okay.
Severe,
Evidence suggests
an ongoing severe sensory motor, axonal and demyelinating polyneuropathic process.
good.
Evident in all extremities tested.
Yep. Now, do we want to? Now, the patient says, my left hand falls asleep at night when I'm sleeping, and it gets better. We may also say that there's some evidence of superimposed focal neuropathy involving the left median nerve at the wrist greater than, just left median nerve at the wrist. Just in case they said it, I don't know. But maybe the patient's also telling you that they've got carpal tunnel. Looks here like they've got median neuropathy at the wrist superimposed on a diffuse peripheral neuropathy on the left side. Would you agree?
Yes.
Good. You made it, Kathy. Was that helpful?
It was very helpful.
So maybe we could go through some more of these sort of like this, and we'll do some more advanced cases. So what you got here is tonight you got an entrapment syndrome, you got a radiculopathy, and a polyneuropathy, and this is sort of what you see every day. And maybe next time I present, I'll throw in maybe a facial nerve or a neuromuscular junction or a plexopathy or something. Just make us think along these lines.
Okay.
Y'all good? You like it?
I'm definitely better, so thank you for that.
Yep.
Awesome, guys.
Appreciate you.
Okay. Hey, thank you for being here. I appreciate y'all attending.
No doubt, man.
I'm going to stop the recording.